Thank you for joining us on this exciting webinar on updates in progressive familial intrahepatic cholestasis prevented by myself and Nadia Ovchinsky. And now I'll hand over to my colleague, Dr. Ovchinsky.
So really one of our drives to do this webinar was to discuss this very recent opinion paper in Journal of Hepatology on new approach to diagnosis and treatment of progressive familial intrahepatic cholestasis, or PFIC. And Pat, you were the first author on this, and I really appreciate your partnership in this. And I want to invite you to tell us a little bit about PFIC and what do we know about pathophysiology of this disease at this point.
Thank you. These are a group of rare genetic single gene disorders which are autosomal recessive inheritance. They tend to present largely in infancy, and the major presentation is with neonatal cholestasis. However, they can present later in childhood and indeed rarely can present in adults. One of the characteristics of these diseases is their severe pruritus. And as any of you who are involved in the management of these children, we know that this has a serious impact on the quality of life. But these diseases are more than a nuisance. They're associated with progressive liver disease, and the majority of children will require surgical intervention or liver transplantation in the first decade of life. The first description of these depended on excellent clinical observation from within the Amish population in Pennsylvania. A group of 4 children descended from the bile family were recognized to have this fatal disease, and which has often been called the eponymous bile disease. Now, it was nearly 25 years later before the mechanism of the disease was explored, and it became apparent there was deficient of bile acids in bile. And then the speed of progress, the progress sped up, and it was 5 years later that the gene for this disorder was described at the same time as a gene for one of the other disorders. And since that time, there have been multiple subtypes of PFIC described, and now diagnostically we use mutation analysis as our primary diagnostic method. As I've mentioned, all of these disorders are single gene disorders, autosomal recessive inheritance, and a single protein that is involved in the production and or the excretion of bile acids into the gut is involved. We know the mechanism of many of these disorders, but some of them remain elusive. The commonest of the diseases are described here in the order in which they were first described. And we tend to call them, give them numerical terms of PFIC, or progressive familial intrahepatic cholestasis type 1, which was the first to be described, the eponymous bile disease. And we can see characteristics that are typical of this disease clinically, in that it tends to present with cholestasis, with relatively modest changes in liver function, in transaminases, sorry. And histologically, we see characteristic appearances of very bland cholestasis with relatively mild fibrosis, although this does progress with time. The other more common type is what we call PFIC2, is probably the commonest type overall. And again, the distinction here is that this is a much more active disease. Transaminases tend to be very abnormal and would advance fibrosis, which progresses quickly to require liver transplantation. And the characteristic of both of those diseases and most of these diseases is the presence of a normal or a low gamma GT in the setting of cholestasis. So how do we diagnose these diseases? Well, first of all, it's in the clinical setting. These children usually present with neonatal cholestasis. if they come from a particular background, there may be a family history, or there may be from a group at high risk of genetic diseases. Jaundice, itch, and of course it's important that in infancy we exclude all other common causes of neonatal cholestasis, including, of course, biliary atresia, which these disorders can mimic. Now, from the practical point of view of how we diagnose a specific disorder, as I mentioned earlier, this almost completely depends on genetic analysis. And we're very lucky to have specific genetic profiles with very short turnarounds, which can give us a consistent and reliable and relatively financially cheap diagnosis. And these are becoming available in most parts of the world now. As I've mentioned, these disorders have a single gene, which causes a protein abnormality. And the first most common type is what used to be referred to as biliary disease, and the mutated gene is ATPB1. And as I've mentioned, this causes a relatively bland cholestasis. The commonest type, where the genetic defect is in ABCB11, and the protein that's deficient is BSEP, the primary protein in the transport of bile acids into the canalicculus. And again, this is a more rapidly progressive disease, and these children are at high risk of developing hepatocellular carcinoma and are likely to require liver transplantation in their first decade of life if we don't have any successful intervention to make. The next one is ABCB4 genetic defect, which causes MDR3 deficiency, is different in that this is a failure. Bile continues to be made, but bile acid toxicity occurs because of the lack of phospholipid. And as a result, these children present with a biliary feature, and rather different, a high gamma GT. And then, of course, as I've mentioned, after the first four disorders were described, there has been recently an explosion in recognition of other forms of progressive familial intrahepatic cholestasis, in which we recognize what the mutated gene is and what the protein deficiency is. And these present very many similarities, although there will be individual differences, like, for example, in tight junction, in TJP2 disease, there may be also respiratory disease. And another of these rare diseases is associated with a high gamma GT. And again, just refer also the one associated with KIF12 is also associated with a high gamma GT, which acts as an earlier marker that this is one of the even rarer forms of progressive intrahepatic cholestasis. What I'd like to emphasize that recognizing these diseases is a clinical issue, recognizing the importance of jaundice, pruritus, fat-soluble deficiency in young children. But to confirm what the specific defect is, that we largely depend on genetic panels, which are very effective and very quick at identifying the mutated gene.